Every single day, our prescription pads dictate the immediate recovery of hundreds of patients. But lately, a deeper question has been weighing on me. Are we truly curing our people or are just managing their symptoms? Today, I want to talk about going beyond the prescription. I want to advocate for a profound shift in how we look at our roles. Why the future of general practice in Namakkal belongs to the doctor who teaches, not just the one he treats. Look at this image. Imagine a clinic standing in the middle of a torrential downpour, completely flooded. What do? We grab mops, we bucket the water out, we try to dry the floor. That's what exactly we have been doing in our clinics today with chronic diseases. We are treating a massive flood of non-communicable diseases, diabetes, hypertension, stroke, ischemic heart disease, while completely ignoring the broken drainage system. Indian general practice is utterly overwhelmed by NCDs that were almost entirely preventable or reversible a decade earlier. If we want to save our community, we have to step out of the clinic and look at the environment, the lifestyle, and the literacy driving the storm. This brings us directly to the unseen healthcare crisis unfolding right in front of us. Look at this number. 70% of all the chronic sickness we encounter daily is driven by a core cluster of metabolic and lifestyle disruptions. We are talking about the true root causes of premature mortality, diabetes, hypertension, obesity, and unmanaged chronic stress. These aren't just isolated diagnoses, they are interconnected systematic failures. The real tragedy of modern general practice is highlighted right here at the bottom of the slide. Because we focus purely on treating established end-stage illness, we consistently miss the early windows of opportunity to reverse the disease development. We wait for the heart attack, we wait for the diabetic foot ulcer, we wait for the stroke instead of aggressively disrupting the habits that create them in the first place. Let us look at the hard data. This is not only a national problem, it's a Tamil Nadu reality sitting right on our doorstep. According to the ICMR India B study, Tamil Nadu has the highest prevalence of adult diabetes in India at 14.4%. The data shows that 33%, 1 in 3 adults suffer from hypertension, and 40% of women are overweight or obese. But here is the most terrifying statistic on this slide. Less than 50% of NCD patients in Tamil Nadu even know their diagnosis until an acute event occurs. We don't need to look at papers to know this. We see it in our own Namakkal clinics every day. Think about a 35-year-old young man who walks into your OPD with a severe headache and his BP is 160 by 100. He has never had a single checkup in his life. Think about the patient who walks in for a routine check with a HbA1c of 9.5%, who tells you they have been taking home remedies for mild tiredness for 6 months. Or look at our automated desk habits, the repeat prescription. The patient walks in, grabs a 3 months refill for the metformin and telmisartan, and walks out without a single question asked about their diet, weight, or whether their siblings have been screened. This is a critical deficit in health literacy. In ortho, we see a lot of young patients with back pain, knee and neck pain, all because of improper nutrition, lack of exercises, and stress. We need to educate them. We often assume our patients know the basics, but the data tells a completely different story. Look at these numbers. Only 40% of patients are aware of the actual danger signs of hypertension. When it comes to adult vaccination schedules, like the annual influenza shot or any other vaccine, awareness drops to a staggering 25%. Only 35% of our diabetic patients actually understand their glycemic targets. Most just know they have sugar, but they have no idea what an HbA1c or fasting target actually means. And look at the early cancer screening at a dismal 15%. Colleagues, these red bars represent the massive gap between prescribing a drug and achieving a successful clinical outcome. If the patient doesn't understand the rules of the disease, they cannot follow the rules of the treatment. Why does prevention fail? Because the awareness gaps in our population is significantly wider than the treatment gap. Look at what our patients actually believe versus what medical evidence proves. A patient tells you, I feel perfectly fine, doctor. I don't need a tablet. But we know hypertension is a silent killer until the day it causes a stroke. They say, I only have sugar if I eat sweets. Refined carbohydrates, white rice, and absolute physical inactivity drive diabetes far more than a spoonful of sugar. They say BP tablets will damage my kidneys. We have to tell them clearly it's uncontrolled high blood pressure that destroys the kidneys. The tablet is what protects them. The casual walk once a week, 150 minutes a week is the absolute bare minimum floor. To bridge this gap, we must actively transition from being a simple dispenser of pills to a designer of habits. Let us compare these two clinical mindsets. If we stick to a treatment only approach, our time horizon is just solving today's symptom, and the patient is a passive recipient. But when we add education, we look at the next 10 years of the patient's life, turning them into an active partner. Instead of their engagement dropping, the moment their symptoms disappears, they stay sustained. Most importantly, your value as a doctor evolves. You're no longer just a prescription pad on two legs. You become their trusted clinical teacher. When you educate a patient, you screen and protect their entire household. General practitioners possess an incredible underutilized public health asset, unmatched proximity. We are the first point of contact for 70% of the healthcare concerns. We see a patient an average of 12 times a year, far more touch points than any super specialty will ever get. We treat three generations of the same family, the grandparents, the parents, the children. Educating a patient in your consultation chair has the power to change an entire village. The data proves it. Systematic clinical counseling and the patient education programs demonstrate a projected 80% decrease in acute hospitalizations for chronic illnesses over 5 years. It improves compliance, cuts long term healthcare costs, and builds an unbreakable bond of trust between you and the family. Now, let us get practical. How do we do this in a busy clinic without running 2 hours behind the schedule? We implement four distinct pillars. Pillar number one is the teach back method. Follow this quick 4-step loop. When you explain a diagnosis, explain the condition simply in 2 sentences and what treatment I am going to give. Ask them back openly. நான் சொன்னது உங்களுக்கு எப்படி புரிஞ்சது? How did you understand what I said? Never ask a said yes or no question like did you understand? If they cannot repeat it, you have not taught, you have only spoken. Correct them gently if they are wrong. And end with one clear actionable behavior they must execute before their next visit. Pillar number two, use clinic ready visual aids in the patient's mother tongue. A busy patient will forget your spoken words, but they will remember an image. Health poster can be made like the one in the slide with features like enter to my plate model, visually breaking down a plate into 50% vegetables, 25% protein, and only 25% rice or millets for diabetes and BP management. It includes a clear BP risk dial divided into easy green, yellow, and red zones, making cardiovascular numbers instantly intuitive. Display the visual showing exactly what 1 teaspoon of salt per day looks like, alongside a clear diabetic food inspection checklist. When the patients see this daily, practical visuals on your walls, medical concepts instantly become real world rules. Pillar number three, prescribe lifestyle behaviors exactly the way you prescribe a drug. Stop giving vague verbal advice like கொஞ்சம் walking போங்க, சாப்பாட்டை குறைங்க. It doesn't work. Instead, take out a dedicated lifestyle treatment pad. Write it down. Walk 30 minutes, 5 days a week. Salt less than 1 teaspoon per day. 2 cups of vegetables per meal. Sleep by 10 p.m. for 7 hours. Bring your BP and sugar log to the next visit, etc. A written medical instruction carries immense psychological weight. When a patient takes a physical lifestyle prescription home, it gets stuck on the refrigerator or somewhere else so that the entire family reads it and holds the patient accountable. Pillar number four, Treat and educate the patient, but educate the family. Non-communicable diseases do not exist in isolation. They cluster in households because families share the same genes, same sedentary routines, and crucially the same kitchen. When counseling a patient, always invite the attender sitting outside into the room. Counseling the attender is essentially screening your next potential patient. Tell the spouse or the daughter who cooks, we need to reframe the kitchen, reduce the monthly oil procurement for the whole house, recruit that attender to be the patient's home health coach. If you change the habits of the person holding the ladle, you protect the health of the entire household. Let us widen our lens. Preventive education isn't limited to adult metabolic syndromes alone. We must look into health literacy across every life stage. Look at this comprehensive framework for maternal and child health. We need to actively display and counsel on exclusive breastfeeding for the first 6 months, proper weaning foods, and strict adherence to INC checkups across all trimesters. We must teach mothers how to spot danger signs in infants and emphasize the vital importance of adult and childhood immunization. Salute. Prevention spans the entire spectrum, from neonatal nutrition to geriatric care. Cancer screening in general practice isn't about running expensive high-end scans. It is about opportunistic screening. It is about using our eyes, our hands, and our clinical suspicion. A 60-second oral look, a routine clinical breast exam, or a brief conversation about cervical screening when a patient comes in for a routine follow-up can catch a malignancy at stage 1 instead of stage 4. Let us make screening a reflex, not an afterthought. To ensure we don't miss these opportunities in a chaotic outpatient department, we need a systematic visit checklist built into our workflow, triggered automatically by who walks through the door rather than relying solely on memory. For every child under 5, a quick check of the immunization card and growth chart. For adults and girls, a routine screening for anemia, a brief check on menstrual hygiene. For every adult over 30, a blood pressure check is a must, and also a random sugar and waist circumference measurement are mandatory, regardless of the why they came in. And for women over 30, we must precisely discuss cervical and breast cancer screening awareness. We must turn every single consultation into a comprehensive screening opportunity. I know what many of you are thinking. Ravi, that sounds wonderful on paper, but I see more patients in my morning OPD. How can I spend half an hour counseling? You don't have to. I present to you the 5-minute education framework, engineered specifically for a busy Indian OPD. It fits perfectly inside a single consultation. Minute 1. Ask, இந்த நோய் பத்தி உங்களுக்கு என்ன தெரியும்? What do you know about this disease? Start exactly when the patient is. Minute 2. Tell, clearly state the diagnosis, point out the silent risk, and name the one target number that matters. Minute 3. Spend 60 seconds pointing at the visual chart, the plate model, or the BP dial on your wall. Minute 4. Pick just one simple behavior change for the month. அடுத்த விசிட் வரும்போது ஒரு மாற்றத்தை மட்டும் பண்ணுங்க. உதாரணத்துக்கு வெயிட் குறைப்பது. Minute 5. Scribble the lifestyle treatment. Note down the return date and hand it over. 5 minutes structured perfectly, saving years of a patient's life. To execute this 5-minute framework seamlessly, we must systematically equip our clinics with the right tools. Turn your consultation room into a highly functional health classroom. A wall-mounted Tamil MyPlate and BP posters, a custom printed lifestyle treatment pad, a glucometer and BP apparatus stationed right at the reception desk so that vitals are pre-checked before the patient sits in front of you, a salt and oil visualizer jar set to demonstrate exact portions, a basic diabetic food care kit, a simple chart with QR codes that patients can scan to watch 60-second health videos in Tamil while waiting, and a clinic WhatsApp broadcast list for monthly lifestyle reminders, and a basic patient logbook. These simple tools convert the passing waiting time into active health education for the patient. As scientific practitioners, we believe in evidence, so we must track our performance to prove that clinical education works. We urge everyone in Namakkal to monitor just 4 key numbers. Your follow-up rate. What percentage of your chronic disease patient actually return at the 3-month mark? Second, your mean HbA1c and blood pressure control. Look at the collective clinical average across your registered patient database. Third, family screening rates. How many first degree relatives of your diabetic and hypertensive patients have you successfully brought in for checks? And fourth, lifestyle treatment adherence. Tracking these metrics elevates our clinics from basic treatment centers into highly effective public health hub. Breaking decades of bad lifestyle habits doesn't happen during a single visit. It requires continuous reinforcement. These are the key phrases that our patients need to hear from us repeatedly until it completely rewrites their health mindset. Prevention is cheaper than treatment. Early treatment saves organs and lives. Lifestyle modification is the best medicine. Regular checkups are essential even without symptoms. If we look ahead, what is the ultimate goal of general practice in our region? A vision for the future of healthcare in Namakkal is built on adding more hospital beds or expanding emergency rooms to treat end-stage complications. The true vision is creating a community so well educated and proactive that our hospital admission rates drastically drop. A healthier Namakkal through preventive healthcare. Doctors should become as a community educators, and we should try to reduce the burden of chronic disease complications, creating a model district for preventive medicine. But let us be entirely honest with ourselves. Implementing this is a real challenge. We operate in a system built on volume where time is limited and patients often expect a quick pill for every ill. The challenge isn't just changing patients' behavior, it is changing our own clinical reflexes. For the lack of time in OPD, the solution is short structured counseling can be done. For low health literacy, use visuals and Tamil language. If there is poor follow up, digital reminders and family involvement should be done. If there is any public misinformation, there should be a strong medical leadership to counter that. This brings us to the collective power in this room, the role of Namakkal IMA. As an association, we shouldn't just be a forum for professional updates. We must be the engine of public health transformation in our district. By standardizing patient education, sharing vernacular visual materials among our members, and speaking with one unified voice, Namakkal IMA can set a benchmark for the entire state. Together, we can shift the narrative of healthcare in our community for reactive treatment to proactive, lifestyle driven prevention. Finally, my dear colleagues, all of these strategies, lessons, and printed prescriptions carry ultimate weight only when we live them ourselves. A prescription for lifestyle modification rings hollow if the doctor doesn't follow. We must lead by example. When we consistently practice what we preach, whether it is maintaining personal fitness, practicing yoga for healthy aging, prioritizing sleep, or managing clinical stress, our patients observe us. A community that watches its local physicians actively living well will follow their guidance with absolute trust and credibility. I want to leave you with a profound thought that beautifully captures the core of our profession. Thomas Edison once formally said, "The doctor of the future will give no medicine, but will interest his patient in the care of the human frame, in diet, and in the cause and prevention of diseases." My dear friends, that future has arrived. Let us embrace the true spirit of healing by stepping beyond our prescription pads and stepping into our roles as teachers, mentors, and lifesavers. Let us take the Namakkal IMA place today. One patient, one lesson for every visit. If every practitioner in this room commits to teaching just one solid preventable health concept at every single consultation, we will collectively prevent more chronic disease in Namakkal over the next 5 years than any government welfare scheme has accomplished in the 50 years' time. Thank you.